then she was MP for Ntungamo, and then she decided to promote herself, so to speak, and ran against a very strong man, the former Deputy Attorney General, Honorable Rukutana, and caused some serious campaign, moments in Ntungamo, but won. Women are very strong in this country, So Honorable Kabashara, it's good to see you and to know that you're going to participate in this important discussion today by chairing the major sessions. You're welcome. We have also been joined by Professor Richard Nam, who is a board member of Uganda AIDS Commission and represents all the cultural institutions in Uganda on the board. Professor, good to see you and welcome. I want to welcome all of you in large numbers. I'm going to request that people who are out of this tent, who are in the exhibition tents, those who are in the posters tents, VIP tents, find their way here so that we start, because we have so far lost 1 hour. We should have started at 9, but participants were trickling in rather slow. But right now, I see a number that we can start with, because there are a number of presentations that have to be had, and so we need to start because we don't want to lose any of them. Those of you with the program, I want to also recognize Dr. Watiti, who is going to chair the first round of activities. I want to run us through the program as it will be today. Today we have half day, and if we all keep time, I expect us to end by 1, so that those of you who are going far out of town can find enough time to travel. We are going to have a number of changes to the program, not the content, not the structure, but especially in terms of the responsible officers or persons. Dr. Watiti will be our main chair of the first session, and he will be assisted by Mr. Raymond Kwesiga of NAFOFANO, National Forum for Persons Living with HIV. So can I find out if Dr. Kwesiga, Mr. Kwesiga is around? Very good. Thank you so much. He's right there. Thank you, Mr. Kwesiga. Yesterday he presented he made a very good presentation. I think yesterday was the first day. Those will be our chairpersons, and then they will start with giving us a recap. Once I've called Dr. Watiti, they will start with giving us a recap of yesterday with the help of their rapporteurs. And then we will have a presentation by PEPFAR, by someone from CDC on PEPFAR contribution in the struggle against HIV/AIDS. We will then have a major presentation on ending HIV with persons with disabilities. And that will be by someone called Robert from the UNAD, the National Association of the Deaf. They are already setting up their presentation. And then we will have a discussion, the plenary, which will be a major part of the program. And once we finish that, we will break for tea. And during that break for tea, we will all move for about 30 minutes to the posters tent, that tent over there. That tent, we have been visiting it, but rather informally. Today, all of us are going to head there during the break, the health break, the break tea time, and we will have lessons to learn from there. The posters authors are already informed so that they can be ready for us and to teach us about the meanings and lessons in those posters. Once we finish that, we will have Honorable Kabasharira taking over from Dr. Watiti and from ourselves, the MCs, and we will then go into the testimony. So on your program manual, you may see Honorable Jessica Abaviku. She is not able to make it. It will be Honorable Kabasharira from Parliament who will take over from there. Then we will have another guest to come for the Philly Lutaya Memorial Lecture, and all this chaired by the session chaired by Honorable Kabasharira will be from the Philly Lutaya tent, which is the other big tent with the red chairs that you see in front of me. Then after that, we will have a presentation of the aid memoir, and then statement by Uganda National Young Positives Association, then statement by the UN Resident Coordinator, and then we will have the closure. All that will be managed by Honorable Kabasharira. So I want to put us on notice that is how the program will run. Allow me now take the singular honor to invite Dr. Watiti to come and start us off, while telling those who are in the tents outside, kindly come to the main presentation tent and participate actively from here. Let's put our hands together, ladies and gentlemen, to welcome Dr. Watiti, a man who needs no introduction in the fight against HIV in this country. He has vowed and said his covenant with his Creator is to live up to 90 years plus. And he's now 70, and he said he has lived for over 35 years with HIV. And we recognize you, Dr. Watiti, in this struggle. We thank God for keeping you, but for giving you wisdom to continue sharing information and educating our people about HIV/AIDS. You're most welcome.
Thank you very, very much. Very much. Let's give him a round of applause as he takes us. I've been seeing him on TV now. We can see him, and he's got a lot of energy when he is leading us. Thank you so, so much. This is our last day, so this is the best of the best. So we are going to have a real great feast today as we do the final lap, and I'm really honored to be here. I will be taking my seat down there, but before I do, I want to invite my co-presenter, my co-chair. My co-chair is my friend Raymond Kwesiga, who is standing in for the Mr. Kentus, who is the executive director of our movement, the national movement, the National Forum for Living with HIV Networks in Uganda. So we will be, I think, sitting there, and then we shall call our presenters who are already in the room. We are honored. We're going to have a great, great, great time this morning. Thank you very much. All right, this is working. Now we want to, let me first hear from my co-chairs, say hi.
Good morning, ladies and gentlemen. Once again, we are very happy to see you this morning. My name is Raymond Kwesiga. I'm also very happy to co-chair my mentor, Dr. Stephen Watiti. Happy to see you all.
Okay. Let's take this time to invite our presenter from PEPFAR, from PEPFAR Coordinating Office, Ms. Rachel Kwesi. Ms. Rachel Kwesi, please come and join us at the podium. You clap until she reaches because she's bringing. Not for us for living with HIV, PEPFAR is like our saying, so when you are coming, you say, Auntie Uyo. Thank you very much. Right.
Yeah, we would like to call upon our other panelists from Uganda National Association of the Deaf, Mr. Robert Nkwangu. He comes along with the interpreter. You're welcome.
So when Nkwangu is coming, if you clap, he's not hearing, so you...
Yes.
He hasn't seen you all. Thank you very much. Thank you very much. Okay, with that done, we really want to dive into the real matter of this and why we're here. As I've already said, we people living with HIV, many of us know that without the coming of PEPFAR, we would not be here. I personally can say that. The coming of PEPFAR to Uganda was a real game changer. I remember at that time I just started working at Biomed and people were dying, real dying. You know, you'll find on a day we would lose so many, like 4 or 5 patients. But with PEPFAR, the story has changed. People who were dying are no longer dying. In fact, the biggest challenge now is how to live longer now that we are not dying of AIDS. And so we are really blessed to have you here, Madam Rachel Kwesi, on behalf of PEPFAR, to come and speak to us on the 20 years of PEPFAR in Uganda, because I remember it was in 2004 when PEPFAR came to Uganda. And many of us who were young, I remember I did not have gray hair, now I have gray hair. So you have made me and many other Ugandans, on behalf of PEPFAR, welcome to speak to us about the 20 years of PEPFAR in Uganda. How we have seen it, but how have you seen it from the other side? Thank you. Over to you. Yeah, you can go and use it. Okay.
Good morning. My name is Rachel Kwesi. I work with the PEPFAR Coordination Office as the Senior Strategic Information Advisor, and I'll be going through a presentation on the 20 years of hope, impact, and partnership. PEPFAR is very broad, but today I'll focus on the impact of art, but we know we have made significant impact through VMMC, through PrEP, KP, and other system investments. Daniel, are you helping me with the presentation? Okay. All right, thank you. So we're going to focus on the scale-up of PEPFAR-supported HIV, ARV therapy, and estimation of HIV infections and HIV-related death. Not sure why. It's not.
Somebody from IT, come and help, please.
So let's reflect on the first case of HIV in Uganda. I think that was way back in 1985. We have made significant progress since then. And a big milestone for PEPFAR took place in January 2003 when President George Bush authorized PEPFAR to support this fight in ending HIV. And in February 2004, a Ugandan man aged 34 years received a diagnosis of HIV infection. The CD4 was 1 cell, and in April, the first person was able to receive PEPFAR-supported ART. That was in April 2004. And in 2023, as we speak now, this man is 54 years old. He remains on PEPFAR-supported ART. He's a teacher and a father to 2 HIV-negative children. So we wanted to also showcase like a summary slide of some of the top-line figures for PEPFAR impact in Uganda since 2004. We have scaled up ART by almost 5,000% from that one individual to where we are now in 2003. ART scale-up has been effective through programming, as seen by the drop in the prevention of mother-to-child transmission rate to below 2%. The viral load suppression rates achieving and sustaining the third 95. And finally, beyond our program data, we have modeled the impact of PEPFAR. That is what would have happened if ART scale-up had not happened. And it has averted 500,000 HIV infections have been averted, including 230,000 estimated infections among HIV-exposed infants. So now the question is, we have made significant progress, as highlighted here, and we are close to reaching the 395s. So some of the key messages we have today. Apologies, I think I'm having some technology issues, but just bear with me, we'll keep moving. So under the leadership of Government of Uganda and in strong partnership with stakeholders over almost 20 years, there has been incredible increase in PEPFAR-supported ART in Uganda, as shown by our program data. As you can see, this slide showcases right from 2004 how much we have scaled up putting people on ART from less than 200,000 to over 1.3 million people in 2002. And I think now in 2003, we are at 1.3 million people receiving ART.
Sorry, I want to interrupt the presenter for 1 second to announce the arrival of our key presenter today, the Honorable Amelia Chambade, former minister. She's here to represent the Deputy Speaker of Parliament, and she will be presenting the Philly Lutaya Memorial Lecture when we go to the next tent. Honorable, you're most welcome for this occasion, and you found when there is a presentation going on the role and contribution made by PEPFAR to the HIV/AIDS struggle, the last 20 years of PEPFAR in Uganda. So enjoy the presentation, Honorable. Thank you.
Thank you. You're very welcome. So we'll move on to our presentation. And there has been critical milestones in policy review to support ART scale-up including program designs that have happened since COVID. The key message is that there's been almost a 5,000 increase in PLHIV on PEPFAR-supported art, increased from 26,000, like I mentioned earlier, in 2004 to 1.3 million in FY22 and FY23, 2003. We have also shown that art is effective in PMTCT, and new infections have been driven down to less than 20%, and this continues to decline. And we are close to achieving virus suppression with a target of 95%, of all the people who have been diagnosed with HIV and are on art, achieving 95% virus suppression, even though the PIDs and the adolescents, as we look at our data, seem to be lagging behind. Art scale-up has been effective. PMTCT rates are below 2%. But what more can we do similarly, and how can we sustain viral load suppression at 95%? Let's look at some of the modeling data we use as PEPFAR. And of course, working in partnership with Ministry of Health. Modeling impact shows that there has been progressive increase in the number of HIV infections averted, as you can clearly see on the graph. Modeling impact also shows that there's been progressive increase in the number of HIV-related deaths that have been averted. In summary, 490,000 total HIV infections have been averted, including HIV-exposed infants. 230 HIV infections averted among HIV-exposed infants, 580 total HIV-related deaths averted. And this is all through the impact of putting HIV-infected patients on art through PEPFAR support. There's been tremendous scale-up of art, which has in turn effectively lowered PMTCT rates and increased virus suppression rates. And as mentioned before, averting over 500,000 infections and deaths. So every year we do annual planning of the PEPFAR program, and we review what we have done in the past few years and where we're going. So in 2023, as we planned for our programming, one of the questions we had is, where are we going together? And I'm going to summarize that in the next few slides. Fortunately, we have a path of how we intend to reach epidemic control as outlined by the strategies put in place. And what you see there as COP20, COP21, COP22, this is each year. COP20 would be FY 2020, 2021, 2022, and now going into COP23, which would be what we're going to do in the coming year. The PEPFAR years start counting from October 1st, 2023, all the way to September 2024. So we have a path of how we intend to reach epidemic control, as outlined in the strategies you see on the screen. And currently, our focus is integration and innovation for person and family-centered programming. integration with Government of Uganda systems and services. Second, holistic community engagement. Third, data for evidence-based programming. And fourth, commodity security. There we go. So let's start at the heart of our strategy with health equity. One of our pillars as PEPFAR going forward is health equity, and that includes closing the remaining gaps for children, for adolescent girls and young women, for key populations, and also finding the men. And we need to fulfill the program, what the program started in 2004. And we need to fulfill that promise for all, not just a few packets of the population, but for all. And we seek to close gaps among children, adolescent girls and young women, and key populations. And in the data that we have that showcases modeling, these are the key populations that are lagging behind and the key populations that have high infections compared to the overall general population. And our conversations have also highlighted that finding men is a key strategy to prevent infections among adolescent girls and young women. Fortunately, we also have a data-driven programming for health equity, and that includes multiple sources we use to analyze our data. Many of you are aware of how we do FIA, which is HIV impact surveys every 5 years. But we also have other population studies we do, and one of them that stands out is CRANE survey, where they do biobehavioral surveys, and they particularly look at key populations and other hidden populations to understand, and we use that data to inform programming, and that helps us to effectively reach the undiagnosed population among the groups I have mentioned, which seem to be lagging behind. Another key thing that PEPFAR is looking at is community leadership. So case finding and prevention strategies will leverage the power of communities, helping their communities to reach the missing populations, to come up with youth-led initiatives, but then also clinical care will continue to decentralize and become integrated within community structures for more patient-centered care. While in the past we have focused so much on the facility, going forward, working together with Ministry of Health, we want to bring our services and our programs down to the community level, and ensuring that we're reaching these populations where they are in the community. And finally, centering program on community is a key strategy for global health security, helping to prevent outbreaks at the source, as well as rapid detection and response to bring outbreaks to a close as soon as possible. Can I ask the IT person to help me run these through as I go? Thank you. I'll just keep saying next slide so we save time. Thank you. PEPFAR will work in concert to strengthen the Government of Uganda approaches for holistic community engagement. By strengthening the frameworks that we all work under, we will advance and progress to the 95-95-95 and the 10-10-10 goals. We are continuing to align current PEPFAR programming with national community health strategy. We're integrating HIV within broader health services and systems, as well as strengthening civil society capacity. Next slide, please. Innovation. Now, this is also very key at the stage where we are to end the epidemic. We want to highlight the need for continuous program innovations around new science, as well as new drugs and technologies as they become available. We also want to ensure that innovations for program management with an emphasis on one, speed, how quickly do we improve timelines for better outcomes, scale, ensuring that these are at scale and they're reaching everyone, not just a few pockets of people in the population, but scaling them up. Adaptability, becoming flexible is needed for unpredictable situations. And finally, value for money, looking toward efficiency, the highest impact at the lowest cost. We have a long legacy to stand on, including adopting innovative technologies to end HIV. We have used audio computer-assisted interviews. This has been used mostly with the Crane survey, where as we do our research and as we reach the key populations in Uganda, we use audio-assisted interviews, where a health worker is not going to ask you questions, but you sit under a computer and you're able to anonymously answer some of the questions that would inform our programming. So we have found that we're able to get more information than someone would give if they were talking to a counselor. So these are some of the technologies we're using, and which helps with person-specific messaging for HIV services around risk reported in a confidential and acceptable manner. One of the other enablers, and I've mentioned this again, I'll mention it, and the emphasis is on leading with data. So it should be evidence-based, action-oriented, continuous, decentralized, and empowered decision-making. And we highlight the importance, you could go back to the previous slide. So here, the importance of not just having data for data's sake. So it's not just about having lots of data, because we really have a lot of data with the paper programming, with all the modeling that we do with UNAIDS and other development partners, but also with Ministry of Health. There's a lot of data that we have, but now we want to use that data for action. And our data use strategy emphasizes providing evidence on which we base decisions, making patient and program level changes for improved outcomes. It should be continuous and should be ongoing, and also it should be decentralized so that people down to the site and community level can also find this data and use it to make decisions and empower decision making. Next slide, please. So moving forward, we can go to the next slide. Moving forward, we have data science and informatics key priorities, as highlighted on this slide. And most of these are governance with leadership, alignment and coordination, skilled data workforce, strengthening facility and community data systems, optimizing analytics for actionable insights, and elevating the science. Next slide. And then one of the other major pillars and what we're focusing on with PEPFAR programming is sustaining the response. So we can do a lot, but we would like to work together with the government to ensure that everything we're doing is sustainable. Everything we're doing, the government is taking the lead, and we are working together with the government. So sustainability is the name of the game going forward, and we look forward to integration to find efficiencies within our PEPFAR program, as well as within the broader health system through alignment with Government of Uganda and key stakeholders. And we recommend acknowledging Government of Uganda's commitment for working together with us to end the HIV epidemic. Moving forward, next slide. We have a good precedent for how this has been done successfully, and this is just one good example of how we have worked together with Government of Uganda and Ministry of Health, and that has been the 10-year supply chain roadmap, where PEPFAR, Government of Uganda, and other development partners came together and came up with a work plan for supply chain, a 10-year roadmap that has principles on how this can be sustained across the 10 years. Next slide. And then one of the other major pillars that we're focusing on currently is public health systems and security. First, for public health among people living with HIV, we need to ensure our large patient cohort is protected and there is continuity of treatment during public health threats. And second, we also want to recognize that Uganda is a unique context for global health security. And this includes the unique epidemiologic context with diseases like Ebola, Rift Valley fever, which are also of global health concern. And the unique epidemiologic context is counterbalanced by long-standing investments that have created a strong cadre of human resources, world-class surveillance and lab systems, and effective supply chain and waste management. Let's move on to the next slide. So transformative partnerships is also another key thing that we're working with as PEPFAR, and we emphasize that the goal is to end HIV together. So we can't do it alone. So we need community partnerships are key. Engaging communities in all their diversity must be a priority to enable participation and inclusion, and we recognize the need to align with Government of Uganda engagement strategy, innovating, including finding innovative financing mechanisms, seeking models that move the HIV response in Uganda from donor-financed response, such as to other schemes, that would handle financing. Then private sector approaches, including programming and financing as well. Next slide, please. We are glad to see that Government of Uganda has a vision for how partnerships fit into the larger sustainability strategy. And we'll continue to work with them. And this has really been a key focus going forward. And we'll have more discussions on sustainability in our coming planning for the next COP year. Next slide. So wrapping up all the pillars that we're focusing on as PEPFAR is really follow the science, which is close to what I mentioned about leading with data, but the legacy of science in Uganda, including initial trials on nevirapine to prevent vertical transmission, circumcision as HIV prevention, treatment as prevention. This has not only impacted programming, translating into lives saved in Uganda, it has also fundamentally impacted HIV policy and programming around the world. And we're continuing to working with the follow the science pillar, working with surveys, and these include, we have the IBBS survey going on. It's the integrated biobehavioral survey that focuses mostly on key populations. We have the UFIRA survey, which is going to come on in the next financial year, 2024, the HIV drug resistance and phylogenetics study also ongoing, and transitional science such as long-acting injectables in a program setting. So all these surveys and trials we're doing fitting into our strategy to inform programming for HIV and also ending the epidemic by 2030. Reaching the 95. In conclusion, we are excited to integrate approaches with Government of Uganda, with our other health development partners, with the civil society, and we're using the PEPFAR 5x3 strategy, which you see there. That is all the key pieces that we need to work on: sustainability, partnerships, community, health equity, innovation, data, global health security, and science. And partnership will help us focus on goals for 2025 and beyond, and together we can end the HIV epidemic in Uganda. Thank you.
Thank you very much. Thank you very much, Madam Rachel Kwesi for that presentation. We apologize for the glitches, but you did a great job. Let's give her another round of applause. I must also apologize that I actually jumped. I was supposed to do a recap. But you know, for me, when you talk about PEPFAR, then put recap and other things, I go for PEPFAR first. Because somebody who picks you from a pit and makes you live, really you cannot forget. I will never forget PEPFAR. Thank you very much. And while we're at it, we know that we belong to the government of Uganda, and as the Baganda say, Nanyi Mufu, Akwata Waunya. So we do request, of course, as we thank PEPFAR, that our government steps up and invests more into health. Many of us who are now contributing positively to national development would be dead without PEPFAR. And we can do better. We can continue doing this with the more funding. I now want to hand over to my co-chair to introduce our next speaker. After that one, after the next speaker, then we shall do the recap. So those of you who came late, you have gained from my misbehavior, but you will get the recap also. Thank you very much. Over to you.
Yeah, thank you, Chair. And, you know, I love the bit of community engagement, and the other word is holistic community engagement. And at this point, we would like to hear from the Uganda National Association of the Deaf, looking at basically ending HIV with people with disabilities. You are welcome, Mr. Robert Akwangu.
You come and sit here and use the mic here. You know we have to, I'd forgotten. He will be voicing, but he will be the presenter, sorry.
He has to be somewhere. Okay.
Yes, thank you very much, Mr. Chair, Dr. Watiti. Good morning, ladies and gentlemen. Good morning, all of you. I'm deaf, I do not hear. And I would like to teach a few sign language to you. Let's sign together. Good morning. Good morning. Yes, thank you very much. You know, when I look at you, I understand the feedback that you've given me. Thank you very much. My name is Robert Nkwangu. I'm the Executive Director of the Uganda National Association of the Deaf. Some of you have been asking what UNAD is all about. UNAD stands for the Uganda National Association of the Deaf, registered by government. We have been in existence for the last 50 years, since 1973, and you're working towards promoting the lives of deaf persons. I use sign language, and I've borrowed the voice of Mr. Wycliffe Bukenya, who is my sign language interpreter. So sign language is very key as a mode of communication for people like me, and it aids us to access communication, participation, and also holistic development. UNAD implements different programs in 5 thematic areas. One being sign language and communication will help deaf persons and government in accessing information. As you can remember, Uganda has over 1.8 million deaf persons in Uganda, and the key challenge is communication and access to information, and many times we've been left behind in different programs because of the communication laxity. And that's why it's very, very important to popularize sign language to help the deaf persons learn from all the programs. And also the aspect of gender is very key, and education that we do, and also we do influence advocacy and make sure that issues concerning deaf persons are embedded within the laws and policies in Uganda, and finally, the livelihoods, to help our people lead decent lives. When I was coming in here at the desk, I reached the registration, and they were struggling to communicate with me, how to be helped, where to sign, and then people were just whispering to me, and they were speaking louder, and it was very big tense. And then finally, I was led someone to come and help me to lead where the deaf persons are. I mean, all that struggle, I thought it would be very, very important for us to understand what disability means and how we can work together with the persons with the disabilities to end HIV, especially when Rachel talked about Pillar 4. An impairment, for starters, is a functional loss of the body. It may be the ears, maybe the eyes, maybe the legs, maybe the limbs. That's an impairment, a functional loss. Then a barrier is an environmental limitation. Where communication becomes limited, take an example, without weekly fear, and I'm only signing, there will be a communication gap. And equally, I and you may not participate and benefit from what I'm doing, but with weekly fear, we are doing away with the barrier. So I want to thank UAC for having this sign language component in their programs. Now, disability is when an impairment with a barrier come into play together. That's when a disability happens. Therefore, disability equals impairment plus a barrier. The Convention Rights of Persons with Disabilities, it says persons with disabilities include those with long-term physical, mental, intellectual, sensory impairment, which in interaction with the various barriers may hinder their full participation and effective participation in society on equal basis with others. As you can see, in Uganda, we have 12.4% of persons with disabilities. And if we use that data from UBOS, and that is estimated to be around 6 million people from the entire population of Uganda, which means it's a group that cannot be neglected, especially in the fight against HIV/AIDS. And I believe it's a group that can ably contribute towards ending this disease. When you talk of the young people, you talk of talk of the women, the children, these categories. But then we forget the idea of persons with disabilities. And I believe it is high time we had them in our programs to help end HIV by 2030 as our agenda. Persons with disabilities are classified into this Washington set of questions, which are usually 4 in nature. And these are internationally accepted. Difficult in seeing as a category of persons with disabilities. This includes the low vision and the totally blind. The second is difficult in hearing. For example, someone like me who is deaf. We also have a category of hard of hearing, difficulty in moving or using part of the body. These are the physical disability. We call the physical disability. And finally, difficulty in remembering, and of course, also concentration. So these are people. These are not mad people like we normally call them, but the different categories of persons with disabilities who need to be part of the fight against HIV. How do we mainstream programs? Remember, the Sustainable Development Goals clearly explain of leaving no one behind. And 4 out of the 17 goals talk of inclusion. For example, access to education, sexual education inclusive of that, and how issues concerning disability can be catered for. The second goal is number 8, is decent work and employment. And also productive inclusion. So all those, goal number 3, which is goal number 10, reduction in inequalities. The social, economic, and political inclusion of all persons. And finally, goal number 17, which is partnerships. And that ideally means working together to address the gaps within us in ending HIV/AIDS. Chair, I'm rushing, forgive me. I'm rushing, but because I'm using another language, I'm a little bit slower. But if you feel I'm rushing, please, you can slow me down. The key issues that we have is 1, persons with disabilities are at risk of HIV/AIDS. We are very vulnerable and at risk. You know, in our society, there are different myths in society. Those that we do believe that say if you have a sexual intercourse with someone with a disability or an albino, you get cured from HIV/AIDS. People think that persons with disabilities, we do not enjoy sex. We do enjoy it, by the way. We do. And women with disabilities are at risk of being raped because they're vulnerable and cannot defend themselves. And this applies also to the young girls with disabilities. And that is why HIV amongst our community is getting higher and higher, because even the negative attitude that the community has towards us, we are really stigmatized. Because, take an example of the deaf people. We live in a society, and our sexual network is within that small group of people. And with this network, we are scaling it out to the rest. So we don't access information on TVs, the radios, you know, all the information about HIV that's always out there. It's normally not accessible to us. And a small attention is given to persons with disabilities. As point number 3, little attention has been given to the challenges, and also persons with disabilities are both vulnerable, have a double vulnerability, because one has a disability, and 2 is suffering from HIV. So the society is going to judge this person extremely hard and harsh. Even many have not accessed education, not gone to school. Comprehending the written literature is quite difficult for them. As you can see, I'll give an example of the deaf people. Mr. Chair, when you come to our society, when one is HIV positive, is going to go on rejoicing, because in a layman language, something positive is something good. Because I'm positive, I'm rejoicing. I've won the exams, I've gotten a plus, I have an A+, I'm good. But yet, in the real sense of positivity with HIV, is something bad. Yet for us, we are rejoicing because we are positive. And the negative, I'll go crying because I'm HIV negative. Because we don't know the depth of all this language. So the community needs to understand this information, especially from people like me. And 90% of people like me have never gone to school. And this category cannot be neglected, ladies and gentlemen, in the fight against HIV. And also, the medical practitioners, the nurses and doctors, the mode of communication towards people like me when you go to access services is quite tense. When the person comes, from my experience, at the registration, the people that struggle to talk to me there, it really shows what happens in the medical centers. So if deaf persons and persons with disabilities at large, usually go for services because of the stigma, and we normally die in silence. In summary, there are key barriers that we need to tackle. One, the attitude. If you tackle the attitude, especially among the health workers and the community, at the family level, looking at persons with disabilities as secondary citizens. Two is if we address the aspect of communication, what we are talking about, putting it in accessible formats would be great. Then three, accessing. The health centers, are they accessible? The physical accessibility, and also the information accessibility. And then fourth is participation. So call upon government in how we can end HIV/AIDS amongst persons with disabilities, and together as a country. One, I feel to be very, very important to mainstream HIV programs. I'll be happy, and I want to record Madam Guest of Honor. A few weeks ago, Uganda AIDS Commission translated the policy guidelines into sign language and also Braille. And it's the first of its kind into this country to have this information accessed for persons with disabilities, and it is easily understood because we know we can end HIV, and also the blind people can also read in Braille on this literature to attain HIV. And the next step moving forward is how we can roll out all this information for the benefit of all our people out there in the country to understand what we are talking about. And also persons with disabilities need a peer-to-peer engagement. If we empower them, such that deaf persons can talk directly to you, Mr. Chair, in sign language without Wycliffe, the interpreter, if we can talk to, because we need to have some private conversation between you and me, and then we don't want the third party to be part of our conversation. So we really need that if we have peer-to-peer engagement and sensitizing one another to communicate how we can mitigate all these challenges and ministers. That will help reduce the stigma. A call for data. When we get some donors, they usually ask us, how many persons with disabilities are having HIV/AIDS? How many of them are accessing the services? So one donor asked me to go back to government or the health centers, the Ministry of Health. When people are recording at the registration, when they're recording their gender, their age, where they're coming from, they never ask the aspect of disability. So I think in that capturing of data, it is high time we had an indicator that captures disability moving forward within this data that we are collecting. And also different categories of persons with disabilities. If one is a physical, if one is blind, one is deaf, one has a mental disability, let us capture all this information, especially when they are registering to get this information. And secondly, the guidelines on how service providers can mainstream disability into their programs. And also the voices of persons with disabilities being heard. Because I believe we are good representative of our constituencies. Like we normally say nothing for us without us. And I believe if you are brought on board, we can ably know how we can control and we can control our people, because it will be very important, because once we listen to people like us, they can ably change their behavior. And Fourth, the budget allocations. If we could have an element of a disability eye in allocating budgets, making the health centers accessible, both in the physical and sign language interpretation, having the health workers trained into sign language and other things, and also having a network with a partnering with the persons with the disabilities, the organization, the OPDs, and that can help because they can they can mobilize their members. And finally, Chair, forgive me for running very fast, but for any issues, please, persons with the disabilities, we are ready to partner together to end HIV/AIDS, and it is a group that cannot be left behind. 6 million plus persons are quite a very big number that we can't forego in the fight against HIV/AIDS. Thank you very much for the opportunity given to me. Robert Nkwangu, thank you very much.
Wow. Let's once again show a sign of appreciation to our presenter, Mr. Robert. Thank you very much. Yeah, at this point, as our technical team prepares the recap, those with questions, please be noting them down. And after the recap, we shall get to the questions.
Let's give a round of applause to the recap. The USC who are coming to remind us of what we did yesterday. And for those of us who were not able to attend yesterday, let's take advantage of this. Thank you.
Thank you very much. Good morning, everyone. We thank God for the good weather, surely. Can we clap for God as we wait for the... yes. My name is Masimbi Brian. I work with UGANDA AIDS Commission as a data manager. I'm going to present the highlights of the day. These are just some of the highlights. We had plenary sessions, and also we had breakaways. Yes, some of the key issues that came up, one of them was HAHA has been misinterpreted by majority of us. The Ministry of Health has come up with a national adaptation plan, which has tried to mitigate the impact of HAHA. This is the Anti-Homosexuality Act in the health setting. Then also we learned about the long-acting ART, which is, for now it's still being used in the West. But JCRC has carried out studies on the long-acting HIV treatment and cure. And this has been basically on the RCT model, the random control trial model, whereby it has the CARE study, the IMPALA study, and the FRESH cohort. So studies are ongoing. This is because we don't want to be left behind, as it was when the ARVs came to Uganda after 17 years. So this time we don't want to be left behind, but also there is a gene therapy that is being adopted in Uganda that is also part of the HIV cure. And also we should note that majority of the presentation has presented on engaging the communities in all aspects of treatment, prevention, reduction in stigma, and positive living. And an example of JCRC, where they have developed a brochure to sensitize the communities about the cure. Then also, favorable legal environment came up during as a key highlight. where some sections of the law should be repealed that criminalize HIV and AIDS should be repealed. And also, Uganda AIDS Commission has come up with an accreditation and e-mapping system. This is for the civil society organizations. Also, it was noted that HIV and AIDS mainstreaming in the public sector is providing an avenue for additional HIV and AIDS funding on top of the donor support. And also across all the presentation, the social support was presented as a different medication for people living with HIV. So we should, as we focus on the care and treatment, as the magic bullet, as they said yesterday, also social support should be highly considered. In this case, the people living with HIV networks should be revitalized as it was before, because it gives hope. It's an altar for these people, so it should be brought up again. Then the stigma and discrimination in schools is still high. We need to find a solution to that. Then the economic support also came up in almost all the presentations yesterday for the people living with HIV, especially for women and young people. As we know that right now the society we are living in is still patriarchy, whereby the resources are owned by men. So these women are left behind in that aspect. Then there is need to implement a robust HIV prevention, care, and treatment, including the PMTCT programs in the prisons setting that came up. So we need to think about these people in the prisons. Then there is an aspect of efficient and effective use of the resources for HIV. We should try as much as possible to avoid wastage of these resources. Then the sustainability plan, after 2030, what next? We need to sustain what we have gained so that we don't fall back into the trap. Then we need to engage the private sector to come up with a way to channel a portion of their community social responsibility to HIV. Here we need to sit on a round table. And also the aspect of the decline in provision of information on HIV came up. It's not the way it was before, so we have declined a bit, so we need to pull up our socks there. This one also came in the community, in the community aspect. Lastly, one of the presenters talked about the investing in prevention interventions pays more dividends in the long run than care and treatment. So members, we need to think about investing in prevention rather than waiting to invest in care and treatment. Thank you very much. That's where the key highlights. Thank you, Chair.
Thank you very much. Thank you so much for the recap. Those of us who either missed it or were not here yesterday.
Our dear key stakeholders.
Now, of course, as my brother was presenting,
symposium. This year,
I discovered that I have a disability which I had forgotten, the difficulty in remembering. And this is a real problem, especially as you grow older, but it's going to be so sometimes I find it challenging. But on a serious note, we need to think more about this, because as people grow older with HIV, and they develop this difficulty in remembering, the question is, how do we expect them to remember to swallow ARVs every day when they are not sick? And this is a real big problem, so we could end up where we began if we do not think about this and look out for ways to solve this problem of difficulty in remembering. Yeah? Something to think about. But now the issue is, we have time for questions for Madam Rachel and for my brother if you have the questions, please put up your hand, or if you have written it, send it to us so we pass them to them. But as you do that, you know, recently we had a real big problem when we heard that there might be no funding for PEPFAR. Can we hear from you that this funding is going to go on, or because I know you, the way you talked, but it was not in your presentation, because, or was it there, maybe I missed it, or maybe I've forgotten. Can you reassure people living with HIV? You know, I say this because I'm the chairman of the National Forum of People Living with HIV Networks. Never mind that from next week I'll not be, because there's going to be an election and I'm not going to be, so you'll be referring to me as the former current chairman. But anyway, my question is, can we get assurance that we are going to have this money for some more time, please?
Thank you, sir. I think our ambassador has spoken publicly that that will continue, but there will be changes, and those changes will be communicated with the government.
Thank you very much. There is going to continue, but we shall look about the but later. So we have to do a lot of work with our government to take over this. We are Ugandans, and we must keep living until God calls us, eventually, at the end. But not through AIDS, surely not. Any other question, please? That was just filling in as you put up questions. Okay, there is no question. Two things. Either they were so clear that everything was understood, or maybe they were not understood. There is a question. There's somebody with a microphone. There's a hand the other side. Yes, one hand there. A hand from a gentleman. I think that's Mr. Magala. Yes. You'll soon have a microphone and ask your question. Direct to the person clearly so that they are able to answer you. Thank you.
Thank you, Chair. And thank you so much. Our PEPFAR, you referred to her as our auntie. Quite a lot of lives have been saved, very productive, and moving on with life. So those are some of the wonders of PEPFAR. You indicated that evidence and data drives what you do or what everybody does. Great achievements that you have shared with us. I'm wondering whether in the course of the 20-year implementation, working together, whether some of the data has come out and there are areas of improvement or areas of innovation. So perhaps hear from you, how has data improved the implementation of PEPFAR program? Thank you.
Thank you very much for that question. Yes, I agree. Data has been very useful in informing PEPFAR programming, particularly for art. Every year we focus on understanding where we are in the cascade. As you're all aware, one of the goals to reach by 2025 is reaching the 95, which would be 95 of people living with HIV have been diagnosed, and 95 of those have been initiated on treatment, and 95 of those are suppressed. So one of the things we do is we analyze using the program results that we collect from within the Ugandan facilities to understand where are we with the cascade. And the last time we did that analysis, we're close to the 95, we're not yet there. And one of the things we've done is what are those major strategies we need to do to close the gaps. Also, the analysis has been able to help us understand who are the missing populations and who are those populations within Uganda that are having challenges with new infections, with maybe not adhering, and one of the major populations that has come up is adolescent girls and young women, and I know that Uganda AIDS Commission is doing a lot of work there as well as UNAIDS to ensure that we're reaching the adolescent girls and young women with different packages. PEPFAR as well is implementing what you've heard of as DREAMS, and really the major focus of DREAMS is to empower the young girls and ensure that they can do what is right for them, but also reduce incidents among that age group. So there are many things we're doing. The other one that stands out is, viral suppression has been low in men, younger men, and our programming is geared, of course, working together with Ministry of Health on how we can improve these, the QI approaches that are discussed within the different technical working groups, at ACP, whether for treatment or for prevention, and we're doing a lot. And then for prevention, really we're focusing on, how we're using prevention strategies like PrEP, VMMC as well to reach the adolescent girls and young women, to reach key populations, and also to help reduce what we're seeing as incidents in the population. So we're doing a lot with the data, and we're going to continue to do that to guide programming. And I think one of the latest one I can mention is that we're working with Ministry of Health to begin early discussions on, HIV impact survey. Thank you.
Thank you very much for that. We soon have. Oh, you have a question there? Okay, lady, yeah, maybe the last one because we are behind set, but please go ahead.
Okay, thank you so much. My name is Nashiba. I work with African Youth Development Link, and we work with young people. And currently we are implementing a project geared towards improving the good health and well-being of adolescent mothers living with HIV. And mine is not necessarily a question, but maybe a comment. I just want to thank Mr. Nkwangu for the presentation and the feedback, but also to call upon the practitioners and actors to not necessarily to view the persons with disability as victims, but to view them as equal partners in the fight against HIV. Because among the adolescent mothers we work with in Bujiri and Busia, we have some of them with disability. And for them it's a double disability because they are teenagers, they are young mothers, and at the same time they are positive, but at the same time they are carrying a disability. So I believe we need to put it into consideration that they have a lot to offer, so we should engage them as partners, not necessarily as vulnerable people. Thank you.
Thank you very much. Thank you. Okay.
Let's
Thank you very much.
One now.
One. Okay.
We have time we are fighting against.
Yeah, thank you very much. I'm John Maogole, a clinical officer from Kabaramaido, but also a palliative care specialist. From our last presenter mentioned about vulnerability, but I would like to note that PEPFAR has been focusing on vulnerable children, and vulnerability is cross-cutting. It is from starting of age to ending of age. It is throughout life. It comes with the life-threatening illnesses. It comes with a lot. So I would like to also call upon PEPFAR to encourage the implementing partners to widen the vulnerability coverage from children to the wider community. This will help us scale up HIV identification. Thank you.
Okay, I think that's a request. We, of course, asking for much, but we certainly are appreciative. In your presentation, you mentioned about holistic community engagement. One of the things we living with HIV have been asking especially is the issue of funding treatment literacy programs, because a lot of our people are struggling You know, it's not very easy to swallow medicine when you are not feeling sick. And these are some of the people who have never suffered from anything, but they have HIV and they need to swallow medicine. So they need to be trained regularly on how to keep swallowing medicine when they are not sick through treatment literacy programs. But thank you very much. Thank you. Let's give a round of applause to our presenters. And a round of applause to you for listening very well. Thank you very much. And on behalf of my co-chair, we want to thank you for allowing us. You can also applaud. Over to you, MC.
Good morning, ladies and gentlemen. A round of applause to our session chairs. Dr. Watiti Stephen, thank you so much. And Raymond Kwesiga from the National PLHIV Forum. I also want to thank our dear panelists from PEPFAR and UNAD. That was quite insightful. And I believe we as civil society, as government, shall be considerate of the key actions recommended, because inclusion is very key in the fight against HIV. At this juncture, I want to invite us for a health break. We are going to have our tea at the poster tent, and we shall be interacting with the poster presenters. I know you've been informally touring the poster stall, but I invite you all, and then I think we should have a tea break of 30 minutes, if you may allow. And then we shall be able to go to the Philly Lutaya corner, and I will invite the Director General, Acting Director General, to lead our delegation and our guest of honor after the tea break for the Philly Lutaya session. That will be marking the end of the National HIV/AIDS Symposium. Thank you so much. I would love to invite Reverend, I don't know if you have Reverend around or Sheikh, to give us a word of prayer and bless our tea. Thank you. Oh. Do we have anyone that can? Yes, please, you're welcome. As our tea blesser arrives, I want to make a little announcement. So we shall have our invited guests. We have the guest of honor and her team have break tea at the, we have a lounge there prepared for her. And then the rest of the stakeholders shall be directed by the ushers the point at which they'll be able to get their health break. Thank you.
Let's humble ourselves and we pray. Father, in the name of Jesus, we thank you so much for the gift of this bright new day. We thank you for all the discussions which is going on. Father, we come to you as your children. We want to commit ourselves to you to serve our country, Uganda, and the whole world in fighting against HIV and AIDS. We thank you for all the presenters. We thank you for the participants, O Lord. And Father, we continue to commit this day to you, that you will continue to speak to us through the different facilitators. We thank you for the gift of the breakthrough which is set before us, O Lord. We remember those who do not have what to eat, O God, that at the appointed time you will provide for them. And for us who have what to eat right now, I pray, God, that you bless and sanctify that which is set before us, O Lord. As we partake of it, O God, shall it nourish our body to gain the strength to continue doing more and more. We pray even blessing upon those who have prepared it, that your hands of blessing be upon them. We pray all this, O God, believing and trusting in your Son, Jesus Christ, our Lord. Amen.
So the other side, I just connect direct. What they are doing, I just continue direct. I start now. Now, Okay, I may go off a bit on Zoom for a few seconds. Twale bino ndabe kasuke mpita wano twale bino tulabe ekiddako
kano kakebo kampi atuwe
yali buli kimu gyekiri type C gyeri come test type C